Okay, let's unpack this. We are diving into a topic today that isn't just, a chapter in a medical textbook. It's a massive, ongoing global challenge. We're talking about acquired immunodeficiency syndrome, or AIDS.
Right. People often call it a modern plague. And for good reason.
Mm.
Even with all the incredible science we've seen, the scale is just staggering.
It really is. We're looking at something like 37 million people around the world still living with HIV, which is the virus that leads to AIDS.
And that number, that sheer magnitude, is exactly why we need to do this deep dive. The history is one thing, but we're really focused today on the clinical reality, the actual mechanics, what happens when the immune system collapses.
So let's define our terms. What exactly is AIDS from a clinical standpoint?
We define it as a state of profound immunosuppression, and it's all caused by the retrovirus, HIV. And this isn't just one infection. It's the catastrophic failure of the master regulator of your entire immune system.
The CD4 plus T cell.
Yeah. Exactly, the CD4 plus T cell. And its failure leads to this really specific and often lethal triad of problems. First, opportunistic infections, or OIs. Second, some very specific secondary cancers. And third, neurological issues.
So our mission today is to shortcut your journey to being genuinely well-informed about how this all plays out. We want to get into not just what happens, but why it happens, and maybe most importantly, how modern medicine has just radically changed the entire picture.
It has. And to really understand the clinical features, you have to follow the natural history of the infection itself. That progression dictates everything: when symptoms appear, what they are, and how severe they get. So we've structured this whole discussion around three very distinct phases.
Right, and those three phases are our roadmap. We're going to start with phase 1, that initial confrontation, the acute retroviral syndrome. Then we'll move into phase 2, the silent and really deceptive chronic infection. Some call it clinical latency. And finally, we'll break down phase 3, clinical AIDS, the full-blown disease where the body's defenses have truly broken down. Let's jump right in. Phase 1, the initial invasion, the acute retroviral syndrome. If someone gets infected today, how soon do they even know something's wrong? What are they actually feeling?
Well, this phase typically kicks in about 3 to 6 weeks after the initial infection. But it's really important to stress that how it presents varies. It varies wildly. Some estimates suggest up to 90% of people will show some symptoms, but they're often so nonspecific that they're just missed or dismissed.
It's usually described as a really, really bad flu, isn't it?
That's probably the most accurate way to put it for a layperson. It's a nonspecific, self-limited illness that feels like the flu. Patients will come in with a fever, often a high one, a sore throat, muscle aches, all over myalgias, and sometimes a rash or diarrhea.
But it goes away on its own.
It does. And that's the crucial part. It resolves spontaneously, usually in about 2 to 4 weeks. And that's because the body is mounting this initial, partially effective immune response. So most people just think, wow, that was a nasty bug, and they move on.
If the symptoms are so brief and, so generic, how often does this acute phase get completely missed by doctors? And does missing it have major long-term consequences?
It is missed constantly, all the time, especially if the person isn't in a group that's considered high risk. And yes, missing it means you delay treatment. And that's critical because even though the person feels better, the virus has already delivered this silent but just devastating blow to the immune system.
Let's talk about that silent blow. What is the virus actually doing in those first 3 to 6 weeks that makes someone so sick?
The acute retroviral syndrome is really the clinical sign of the virus, just spreading like wildfire through the body. It's disseminating everywhere. And it's targeting and destroying key immune cells. The primary targets are the memory CD4 plus T cells.
Okay, which ones specifically?
Particularly the ones that live in mucosal lymphoid tissues. Think of the gut-associated lymphoid tissue, or GALT.
And why are those memory T cells in the gut singled out for this first big attack?
It's because the mucosal tissues, especially in your GI tract, they hold the largest single reservoir of memory CD4 plus T cells in the entire body. And these particular cells are highly susceptible because they have the right docking station for HIV, the CCR5 coreceptor.
So the virus has an easy entry point.
A very easy entry point. Gets in, replicates on a massive scale. That's when you see peak viremia. And it causes a staggering initial wipeout of this huge T cell population. We're talking about potentially half of the memory T cells in the GALT being destroyed in just this acute phase. And that causes huge problems for the mucosal barrier, which then lets other microbes cross into the bloodstream easily.
That's profound. So the very foundation of the immune system is cracked right at the beginning, long before you even get to the chronic phase. But you mentioned the body does fight back.
Oh, absolutely. The body isn't passive. As the virus is exploding, the immune system sounds the alarm. Within days, you see this dramatic rise in HIV-specific CD8 plus cytotoxic T lymphocytes, CTLs.
The assassins of the immune system.
That's a good way to put it. They're highly specialized killers, and they're critical for getting that initial explosive viremia under some sort of control. The CTLs start killing off infected cells, and that causes the viral load to drop significantly from its peak.
And the balance that's struck here defines one of the most important measurements we have, the viral set point. This is where the science really connects directly to a patient's future, isn't it?
It's absolutely critical. The viral set point is that stable, low level of HIV-1 RNA that you can still detect in the blood after the acute phase is over and the CTL response has done its job. It basically represents the equilibrium that's been reached between the virus trying to replicate and the host trying to contain it.
So if you happen to have a genetically strong initial immune response, your set point will be lower, and if not, it'll be higher.
Precisely. The set point is, in essence, a direct reflection of how vigorous that initial immune response was.
Yeah.
And what's so fascinating is its incredible predictive value for how quickly that patient will progress to full-blown AIDS.
How dramatic is that predictive power? Can you give us some numbers that really stick?
The difference is night and day. It's huge. Studies show that patients who establish a low viral load set point, let's say under about 4,500 copies of viral RNA per milliliter of blood, they have a much, much slower disease course.
Okay.
In fact, only about 8% of those people will progress to clinical AIDS within 5 years. Only 8%.
And on the other end of the spectrum?
Now, compare that to patients with a high set point, say, greater than 36,000 copies. A shocking 62% of them will develop AIDS within that same 5-year window.
62% versus 8. That is a life-altering difference. It really shows how critical that first skirmish is, the one between the CTLs and the virus, in setting the clock for the entire disease.
It's a natural prognostic marker, and it's all determined by the host's immediate genetic and immunological ability to respond.
That brings us to phase 2, the hitting battle, the chronic infection, or what some people call clinical latency. If the virus has reached this equilibrium, this must be that long period of deceptive calm.
It is the longest and absolutely the most deceptive phase. Clinically, patients are pretty much asymptomatic, and this period, if you don't get treatment, can last anywhere from 7 to 10 years, sometimes even longer.
But you're calling it deceptive. Why is latency a misleading term here?
Because from a pathological perspective, it's anything but latent. While the virus is hiding out as a provirus in some resting cells, in the lymphoid tissues, the lymph nodes, the spleen, the battle is just raging continuously.
How big is this battle?
We are talking about continuous, rampant viral replication. The source material highlights a truly mind-boggling number. Up to 2 billion CD4 plus T cells die every single day during this phase.
2 billion cells every day.
Every single day. That's the real scale of the internal war that's going on. The body must be working in absolute overdrive just to keep the person feeling well.
It sounds like a sinking ship where the pumps are going full blast just to keep the water level steady.
That's a perfect analogy. Early on in the chronic phase, the immune system's keeping pace. It's replacing the destroyed CD4 plus T cells almost as fast as they're being lost. But this constant, massive renewal effort puts an incredible strain on the bone marrow and the lymphoid organs. And over the years, the T-cell erosion just becomes relentless. The host's ability to make fresh CD4 plus T cells eventually can't keep up. The ship slowly starts to sink.
And as those pumps start to fail, the patient starts to show some small cracks in their armor, right? Even before the full collapse. What are the clinical warning signs we see during this long chronic phase?
These are the low-grade illnesses that signal that immunologic decompensation is starting. A patient might come in with persistent generalized lymphadenopathy, that's swollen lymph nodes, or some minor opportunistic infections.
Such as?
Things like oral candidiasis, which is thrush, vaginal candidiasis, recurrent outbreaks of herpes zoster, which is shingles, and, very importantly, tuberculosis.
Tuberculosis is a big one here, isn't it? We usually think of these opportunistic infections as happening at the very end, but TB shows up pretty early.
It does. TB is a unique global threat in the context of HIV. It often shows up relatively early in the disease, well before the CD4 count drops below 200. This is especially true in resource-poor regions. The synergy between HIV and M. tuberculosis is highly destructive, and its presence is a very serious warning flag.
These signs are what lead doctors to rely so heavily on the CDC staging system, using the CD4 plus T cell count as the main tool for management. Could you walk us through those categories and why that 200 cells per microliter threshold is so important?
Of course. So the CDC divides HIV infection into 3 categories, and it's all based on the absolute count of CD4 plus T cells per microliter of blood. Category 1 means a relatively healthy immune system. Your counts are at 500 cells or greater. At this stage, the risk of a serious opportunistic illness is low.
Okay, that's the safe zone.
Relatively. Then you have category 2, which is the transition zone. That's 200 to 499 cells. This is where we start seeing those minor infections we just talked about, the thrush, the shingles. The immune system is clearly struggling, but it's still largely functional.
And then there's the critical threshold?
Yes. Category 3. That's defined as having fewer than 200 cells. This number, 200, is the official immunological definition of AIDS. When the count drops below this point, the entire risk profile changes dramatically. The patient becomes highly vulnerable to the life-threatening infections that define the final phase of the disease.
That framework really sets the stage for the true collapse. Once that CD4 count falls below 200, the defenses are, for all intents and purposes, gone. Let's talk about how that system failure actually manifests in the body.
This is where the profound loss of that master regulator, the CD4 plus T cell, finally leads to a symptomatic, catastrophic collapse. The general presentation itself is just debilitating. Patients will have a long-lasting fever, sometimes for over a month, severe fatigue they can't shake, and profound, unexplained weight loss. We often call that wasting syndrome.
And other symptoms?
Chronic diarrhea and persistent generalized lymphadenopathy. And crucially, at this point, the viral load shoots up again because there aren't enough T cells left to contain it. This is what leads to the severe life-threatening AIDS indicator diseases.
And the primary killers in this phase are the opportunistic infections, the OIs. These aren't new germs attacking the body.
That's the key. These are pathogens that were successfully held in check for years, sometimes decades, by a healthy immune system. Once that T-cell surveillance disappears, the floodgates just open. T-cell-mediated immunity is what's required to control all these latent pathogens.
Well, when it fails?
When it fails, these previously harmless microbes reactivate and just proliferate without any checks. The vast majority of deaths in untreated patients are because of these OIs.
Let's start with the fungal infections. These were really the signature manifestations that first brought AIDS to the world's attention back in the 80s.
The single most iconic fungal infection is pneumocystis jirovecii pneumonia, or PCP. Historically, this was a major presenting feature. It accounted for up to 20% of initial AIDS diagnoses.
And it's caused by a fungus most of us already have.
Exactly. It's a fungal organism that most healthy people carry completely asymptomatically. When it reactivates in an immunocompromised person, it causes this diffuse interstitial pneumonitis.
What does that actually look like for the patient? What are they experiencing?
It's often insidious. It creeps up. The patient will have a fever, a dry, non-productive cough, and this progressive shortness of breath, or dyspnea, especially when they exert themselves. What's tricky is that their lungs might sound deceptively clear when you listen, but their gas exchange is severely impaired. It's a classic sign of severe immunosuppression.
Then there's candidiasis, which is often the first thing you can actually see.
Right. Candida is the most common fungal infection overall. It usually shows up as thrush in the mouth, these white patchy lesions. It can also cause vaginal candidiasis.
And when does it become an official AIDS indicator?
The critical point is when it moves beyond the mouth and into the esophagus. That causes pain and difficulty swallowing, or autophagia. That is an AIDS-defining condition. In fact, seeing oral thrush in an otherwise asymptomatic HIV patient is often the canary in the coal mine. It frequently signals a rapid transition to Category 3 status is coming.
And moving systemically, what's the fungus that targets the central nervous system?
For that, we have to talk about Cryptococcus neoformans. This is a very serious threat. It primarily causes a chronic meningitis, and we see it in about 10% of AIDS patients. They present with headaches, fever, and neck stiffness. It's a terrifying sign of just how profound the immune failure has become.
Allowing a fungus to cross the blood-brain barrier.
Exactly.
Let's shift to the viral invaders. Which latent viruses come roaring back to life when that T-cell surveillance is gone?
Cytomegalovirus, or CMV, is a huge one. It's from the herpes family. While it can cause disease throughout the body, in the lungs and GI tract, its most classic and devastating location is the eye.
What does it do there?
It causes CMV chorioretinitis. It's an inflammation of the retina that can, and often does, lead to blindness. This eye infection is a hallmark of extreme immunosuppression. We almost exclusively see it when the CD4 count plummets below 50. It truly signals end-stage disease.
So we also see the other herpes family viruses causing problems.
We do.
Mm-hmm.
Herpes simplex virus, HSV, shows up as these persistent and often excruciatingly painful mucocutaneous ulcerations. These aren't just your typical cold sores. They're chronic lesions that just fail to heal because there's no T-cell response. They can be in the mouth, the esophagus, the perianal region.
And then there's the JC virus.
Yes, the insidious JC virus. It's a human papillovirus, and it targets the oligodendrocytes in the brain. It causes a condition called progressive multifocal leukoencephalopathy, or PML.
And PML is one of those diagnoses that clinicians really fear because the damage is often permanent.
It is. It carries a terrible prognosis. PML involves the progressive destruction of the brain's white matter. This leads to visual loss, cognitive changes, often weakness on one side of the body. It's a rapid and often fatal neurological decline.
Let's turn to the bacterial pathogens now, specifically mycobacteria. We have to distinguish between two major threats here, TB and MAI.
This distinction is absolutely crucial for how you manage the patient. First, Mycobacterium tuberculosis, TB, the classic one. Worldwide, nearly a third of all AIDS deaths are still because of TB.
And as we said, it strikes early.
It strikes early in the course of AIDS, before the most severe immunosuppression sets in. And in HIV patients, it often presents as atypical or extrapulmonary disease, which can make it hard to diagnose. It's a massive public health problem.
So TB needs a slightly less collapsed immune system to really take hold. What about the atypical mycobacteria, like MAI?
That's where Mycobacterium avium intracellular, or MAI, comes in. This causes the disseminated bacterial infection, but it happens late. We see it in the setting of severe immunosuppression, usually when the CD4 count is below 50.
And what does that look like?
MAI causes a systemic illness. Fever, night sweats, weight loss. It often affects the liver, spleen, and lymph nodes. It requires profound end-stage immune failure to spread so widely.
Okay, before we move on from OAIs, what about that relentless, debilitating chronic diarrhea we associate with the wasting syndrome of advanced AIDS?
Persistent, profuse, watery diarrhea is a common cause of malnutrition and death in advanced, untreated patients. It's often caused by protozoans, particularly Cryptosporidium and Isoporabelli. These parasites cause a chronic infection of the intestinal lining, and that leads to massive malabsorption, huge fluid loss, and just relentless weight deterioration. The patient simply can't maintain nutrition or hydration.
So beyond the opportunistic infections, the loss of T-cell surveillance also takes the brakes off certain cancer-causing viruses. Let's move to secondary neoplasms, which affect, 25 to 40% of untreated individuals?
Right, and these tumors are not random at all. They're highly specific cancers, and they're driven by oncogenic DNA viruses that a healthy T-cell system normally keeps dormant. When that T-cell surveillance fails, these viruses are free to proliferate and drive malignant transformation.
And the most famous historically defining example is Kaposi sarcoma, or KS.
Correct. KS is the most common neoplasm in AIDS patients. Early in the epidemic, before we had effective treatments, up to 30% of infected homosexual men presented with this tumor. It's a vascular tumor, and it's caused by human herpes virus 8, or HHV8.
How does the KS we see in AIDS patients differ from the classic non-HIV form?
It's just far more widespread and aggressive. The lesions are these purplish or brownish plaques and nodules, and they appear on the skin and mucous membranes. But in AIDS, it routinely involves internal organs, the GI tract, the lymph nodes, even the lungs, which can lead to severe pulmonary compromise.
I think the source mentioned something interesting about the cells themselves, that it isn't quite a straightforward malignancy.
That's a crucial insight. The HHV8 infection drives the release of these potent pro-inflammatory and angiogenic factors, things that promote blood vessel growth. This leads to a hyperproliferation of the affected cells. So it's more of a reactive, HHV8-driven process that looks malignant and certainly acts aggressively, but it's all driven by the T cells failing to suppress HHV8.
The other major cancer concern is B-cell lymphomas. They occur at a rate at least 10 times greater than in the general population. The source material lays out two distinct mechanisms for how these lymphomas develop in HIV. Let's slow down and really define those two pathways.
This is a complex but really vital concept. The two mechanisms really depend on when the cancer develops during the course of the disease. You have lymphomas driven by chronic immune activation early on, and then you have lymphomas driven by severe T-cell depletion later on.
Okay, let's take the later stage ones first, the ones caused by the total loss of the immune security system.
Right. This happens when the CD4 count is severely low. T-cell immunity is basically the security guard that's supposed to restrain B cells infected with oncogenic viruses like EBV and HHV8. When the T cells are gone, these viruses multiply and drive the infected B cells into this aggressive, uncontrolled proliferation.
And which specific lymphomas come from this complete loss of control?
We see types like EBV-positive large cell lymphoma and, very distinctly, HHV8-positive primary fusion lymphoma. That one's unique because the tumor cells often just float in body cavities. We also see that EBV infection is tied to the majority of HIV-associated Hodgkin lymphoma cases.
Now, for the second, more subtle mechanism, the one that happens earlier in the infection, related to chronic activation.
Right, this isn't about immune deficiency, it's about chronic immune overstimulation. Early in HIV infection, you get this profound germinal center B-cell hyperplasia. It's a massive overgrowth of B cells, and it's all driven by the chronic inflammatory state the virus causes.
And the germinal centers where B cells are naturally going through some very error-prone processes.
Exactly. B cells in the germinal centers are supposed to be mutation factories. They undergo processes that naturally introduce breaks in their DNA. Chronic stimulation just turns this normal process into a highly error-prone environment, which dramatically increases the chance of acquiring dangerous genetic translocations.
So the resulting tumors are basically cancers of opportunity created by this biological chaos.
Precisely. They pick up translocations of oncogenes, like the MYC translocation we see in Burkitt lymphoma, or others that lead to diffuse large B-cell lymphoma. These cancers are aggressive and fast-growing, but their origin is in that chaotic, overstimulated B-cell environment, not just the T-cell's failure to contain a virus.
Finally, we have to mention the increased risk of epithelial cancers linked to HPV.
Yes, human papillomavirus-associated squamous cell carcinomas, particularly of the cervix and the anus. This is a major increasing threat. The lack of T-cell surveillance means the body can't clear HPV infection effectively. The precursor lesions, SILs, are a shocking 10 times more common in HIV-infected women.
And they progress faster.
Dramatically faster. The rate of progression from a precursor lesion to overt invasive cancer is accelerated in HIV-infected individuals. This just highlights why proactive, regular screening isn't just important, it is absolutely vital for this population.
The destruction extends beyond the body and the lymph system into the most vital control center, the brain. Let's get into central nervous system disease, which affects between 40 to 60% of patients clinically.
Neurologic manifestation is a critical part of AIDS morbidity. It often appears late, but in some unlucky patients, it can be the first and only sign of HIV infection. The most common specific HIV-related change in the brain is a progressive encephalopathy called HIV-associated neurocognitive disorder, or HAND.
The classic finding here, and a key point for our listener, is that the virus isn't directly infecting the neurons themselves. The damage is indirect.
That is the absolute key pathological detail. Neurons are spared. The primary problem is caused indirectly by the infection of the brain's resident immune cells, the microglia. Microglia are part of the macrophage family, and they are the main cell type that HIV infects in the brain.
So the damage is essentially collateral damage, a tragedy caused by the brain's own immune cells turning toxic. How does that happen?
It's a cascading inflammatory failure. The HIV-infected microglia get activated, and they start releasing this toxic cocktail. It includes some viral products, but more importantly, it's high concentrations of toxic host factors. Inflammatory cytokines like IL-1, TNF, and IL-6.
And these are the things that are supposed to fight infection.
Right. But here they cause excitotoxicity, oxidative stress, and ultimately neuronal damage and apoptosis programmed cell death.
What kind of symptoms should we associate with HAND? How does this neuronal damage actually show up?
HAND is a spectrum. It can range from minor cognitive impairment all the way to severe dementia. Clinically, it's a triad of deficits. First, cognitive issues, trouble concentrating, forgetfulness, mental slowness. Second, motor problems, difficulty with fine motor skills, slow movement, and unsteady gait. And third, behavioral changes like apathy or social withdrawal. It's a progressive loss of intellectual and motor function.
But beyond HAND, the CNS is also a magnet for the opportunistic infections we've already talked about.
It is the final frontier for these OIs. If an AIDS patient has CNS symptoms, the differential diagnosis is incredibly complex and urgent. We mentioned Cryptococcus causing meningitis. Another very frequent invader is the protozoan Toxoplasma gondii.
And that causes abscesses in the brain.
It does. Toxoplasmosis is responsible for about half of all the focal mass lesions we find in the CNS of AIDS patients. This often presents with focal neurologic deficits, seizures, things like that.
And of course, the JC virus leading to PML, The convergence of all these infections and hand must make CNS management incredibly complicated.
It really does. It highlights why you need a comprehensive workup anytime an AIDS patient shows up with new neurological symptoms. The treatment for a virus like PML is radically different from the treatment for a protozoan like toxoplasmosis.
Okay, everything we've just discussed paints this picture of a relentless, specific, and ultimately fatal syndrome. But medicine, thankfully, has completely rewritten that story. Let's move to the clinical revolution of art. The game has changed.
The therapeutic landscape has shifted so dramatically. AIDS has been transformed from what was a death sentence into a manageable chronic disease, at least for the vast majority of patients who have access to care. And this revolution is entirely due to combination antiretroviral therapy, or CART.
What makes that combination approach so essential? Why can't doctors just use one powerful drug?
It's driven by the very nature of HIV. It's a retrovirus with an alarming degree of molecular variation. Its reverse transcriptase enzyme is notoriously sloppy. It makes mistakes all the time. That means the virus mutates constantly and rapidly.
So a single drug would be quickly overcome.
Exactly. If you use only one drug, resistant mutants will inevitably pop up and take over the population in a matter of weeks or months.
So the combination therapy is like a strategic roadblock.
That's a great way to put it. Combination therapy uses 3 or 4 drugs, often targeting 3 different steps in the HIV life cycle at the same time. You block reverse transcriptase, you inhibit protease, and you often block integrase. This multi-pronged attack makes it statistically almost impossible for the virus to acquire all the necessary resistance mutations at once.
And what's the gold standard we're aiming for with modern treatment?
Achieving an undetectable viral load. CART, when a patient adheres to it rigorously, can reduce the HIV viral load in the blood to below detectable levels, usually less than 50 copies of RNA per milliliter. And it can keep it there indefinitely. The concept is so central now that we say undetectable equals untransmittable, or UU.
And this viral suppression must lead to a reversal of the immune failure we spent so much time detailing.
It produces spectacular results. The progressive loss of CD4 plus T cells stops completely. Even better, the CD4 count slowly starts to climb back up. Over several years, it can return to normal levels, essentially rebuilding the immune infrastructure that was so badly damaged.
So this immune reversal has just radically altered the clinical picture. The classic AIDS-defining conditions, PCP, KS, CMV retinitis, we just don't see them as much in treated patients anymore.
In developed nations, they are now described as very uncommon in patients who are on CART. The restored immune function is enough to contain those latent infections again. The annual death rate from AIDS has plummeted by more than 80% since its peak in the mid-90s.
But this incredible therapeutic success hasn't come without a price. This is the new frontier of AIDS care. We're trading a rapidly fatal disease for a complex, manageable one, but new challenges are popping up.
That's exactly where the current challenge lies. We have 2 major areas of new morbidity that clinicians are constantly grappling with. The first is the paradoxical immune reconstitution inflammatory syndrome, or IRIS.
That sounds completely counterintuitive. The patient gets sicker because their immune system is recovering.
It's a profound clinical challenge. IRIS happens in patients with advanced disease who start RT and their CD4 counts begin to rise. But despite the falling viral load, the patient gets clinically worse. They'll present with fever, localized pain, or big inflammatory responses at sites of old infections.
Why does that happen? Is the newly revived immune system just poorly calibrated?
That's the leading hypothesis. The newly mobilized recovering immune system is like it's waking up after years of being suppressed. And it suddenly encounters all these persistent microbes like latent PB or cryptococcus that it was previously ignoring. And it mounts this poorly regulated, excessive inflammatory response to these old enemies. Essentially, the immune system is overreacting and causing tissue damage.
The second and maybe more pervasive long-term challenge is the toxicity and metabolic consequences of taking these drugs for life.
We've bought survival, but the drugs carry a metabolic cost. Especially the early drug classes, the NRTIs, they were associated with a lot of mitochondrial toxicity. And this damage leads to significant side effects like lipoatrophy, that's the characteristic, disfiguring loss of fat in the face and limbs, and lipoaccumulation, which is fat deposition in the center of the body.
So we see changes in body fat, but the toxicity goes way beyond just aesthetics. It hits major organ systems.
Absolutely. The drugs, combined with the residual chronic inflammation from the virus, lead to a profound metabolic syndrome. We see insulin resistance, abnormal lipid levels, and an acceleration of cardiovascular, renal, and liver disease. This long-term inflammation and drug toxicity accelerates atherosclerosis, so HIV-positive individuals on long-term RT face a significantly higher risk of heart attacks and strokes, often years earlier than the general population.
So what does this all mean for the patient today? The causes of death have shifted entirely from these acute infections to chronic non-AIDS issues.
It's a tectonic shift in clinical practice. Because the CD4 counts are normalized and the classic OIs are contained, non-AIDS morbidity, heart disease, kidney failure, non-AIDS cancers like lung and liver cancer is now more common than classic AIDS-related problems in long-term treated patients. The focus has decisively moved from managing acute, life-threatening infections to managing chronic metabolic diseases accelerated by both the virus and its treatment.
A complex new reality. But despite all these incredible advances, a definitive cure is still out of reach. This brings us to the unresolved challenge: latency and cure.
The central obstacle standing between chronic management and a cure is the persistent, latent viral reservoir. Even when the viral load is undetectable in the blood, the integrated provirus, the silent HIV DNA, is still there. It's hiding,
Where is it hiding?
primarily within long-lived resting memory, CD4 plus T cells and macrophages, especially in the lymphoid tissues.
And this reservoir is invisible to both the immune system and the drugs.
Precisely. The drugs we have are highly effective at stopping new infections, but they can't do anything about the integrated provirus that's hiding silently in the host genome. And these resting memory T cells can survive for years, even decades.
And if you stop treatment, that reservoir just reawakens the whole infection.
That is the tragedy. We have compelling evidence that even patients who've been undetectable for years will see the infection come roaring back if they stop their medication. This persistence means lifelong adherence to treatment is necessary, which is a massive personal and public health burden.
And what about the other side of the cure, a vaccine? That molecular variation we talked about at the beginning seems to be an insurmountable barrier there too.
It makes vaccine development extremely difficult. The high mutation rate means the viral envelope protein, the part the immune system usually targets, is a constantly changing target. The ultimate goal, the true cure, requires finding a way to activate, expose, and then eradicate that latent viral reservoir without harming the patient. The so-called shock and kill strategy, which is proving immensely difficult to perfect.
We have covered this staggering journey of a disease, from the devastating initial assault on mucosal T cells and the establishment of that critical viral set point.
Through the years of silent internal war, with 2 billion cells dying daily, to the ultimate collapse with its specific opportunistic infections and virus-driven cancers like Kaposi sarcoma.
And we've seen the profound transformation brought about by combination RT.
Right. It moved the disease from a rapidly fatal syndrome to a complex, manageable chronic condition. We see that monitoring the CD4 count and viral load is still the absolute foundation for clinical management.
The ultimate goal, of course, remains finding a way to cure that persistent latent virus.
Indeed. While mortality has dropped, the defining challenge of HIV medicine today lies in managing the non-AIDS-related chronic diseases, the cardiovascular, the metabolic, the renal issues that are accelerated by both the virus and its treatment. This requires a complete reevaluation of public health strategies, moving from acute infection management to comprehensive long-term chronic care for an aging population of HIV-positive individuals.
That persistent latent reservoir isn't just a molecular curiosity, it is the boundary we're still fighting to cross. What does the shift mean for funding and infrastructure moving from emergency response to lifelong care for millions? That is the question that shapes the next decade of this fight.